Alright, next we're going to look at the laboratory and diagnostic test. First we're going to look at analysis of a urine specimen. What we look for here is your patient hydrated, or are there any signs of infection, protein in the urine for preeclampsia. The blood tests that are typically ordered are a CBC. If the patient has not had prenatal care or their HIV status is not documented, that will also be ordered, and a type and screen, which shows the blood type and the RH status. For the assessment of the amniotic membranes and fluid, labor is initiated at term by spontaneous rupture of membranes in approximately 25% of women. So what that means is about approximately 25% of women, labor starts at the time that their water breaks spontaneously. AROM or AROM is when the provider performs an amniotomy, and this is when the provider uses an amniohook to rupture the membranes. So that stands for artificial rupture of membranes. You want to record the time, the fetal heart rate, the color of the fluid, the odor of the fluid, and the amount of the fluid. And again, once the membranes are ruptured, whether artificially or spontaneously, you want to limit vaginal exams and record maternal temp at least every 2 hours. So you're monitoring for what we call choreo and placentitis. So you're looking for infection in the uterus or the placenta. Other tests are their Group B strep status. If it's unknown, a lot of hospitals can do a rapid test to see if the patient is Group B strep positive or not. Some hospitals that don't do the rapid, if the GBS is not known, they just automatically give the patient antibiotics. Signs of potential problems are located on page 444 in your book. It has signs of potential complications. For plan of care and interventions, standard of care is listed on page 445 in box 19-7. So this gives evidence-based care practices that are designed to promote, protect, and support normal labor and birth. Physical nursing care during labor, starting with general hygiene. Warm water decreases the pain, so we'll look at some pictures later, but if you can just put warm water on the abdomen and on their back, it lessens the pain for the patient. And, you know, one of the really big things as a nurse is taking care of your patients from head to toe and not delegating everything. You know, you think when you go into med-surg nursing, you know the body fluids that you're going to deal with. Well, it's the same with OB, except there's additional body fluids, but it's important to change the linen that becomes soiled under the patient, whether that's with urine, amniotic fluid, blood, or feces. It's important to keep them clean. Next is nutrient and fluid intake. Usually solid food is discouraged due to the risk of aspiration, so patients usually do not eat solid food during labor, and that's related to general anesthesia and just in the unlikely event that they were to have some kind of emergency. As labor progresses and pushing slows, the progress of labor and pushing slows if patients don't get enough intake, fluid mostly, their hydration status, if there's not enough intake. So dehydration affects the progress of labor and delivery, especially when they start pushing. Common hospital practice is to allow clear liquids and ice chips only, and the use of IV fluids maintains hydration. The typical IV fluids that are used during labor are normal saline and lactated ringers. Next, under your nursing care is elimination. You want to make sure patients void at least every 2 hours. A distended bladder can prevent the baby from coming down in the pelvis or prevent fetal descent. If a patient has any type of bowel movement, usually they're very, very embarrassed. The same muscles that you use to push your baby out are also the same muscles that you use to have a bowel movement. It's very common for BM or stool to be expelled during the pushing. but it's not enough evidence to support routine enemas that used to be given all the time. So again, it's just very embarrassing for the patient. So as the nurse, you just, keep the female's bottom cleaned up. Actually, you encourage them that they're pushing well when that happens, because it's moving the baby down also. But they're very embarrassed by it. So one thing to note, if any patient complains of rectal pressure, you want to do a vaginal exam to assess the dilation and station. Especially if they have an epidural, sometimes the first sign that they'll have that they're ready to push is they'll complain of a lot of rectal pressure. So if they feel like they need to have a bowel movement, rectal pressure, you definitely want to do a vag exam and see how they're progressing. For ambulation and positioning, you can see we've talked about the hands and knees position, knee chest. So what you see in the picture of B is a patient in hands and knees. If the patient were on her elbows, it would be a knee chest position. We've talked about that, but you can see how the supporting significant other here has access to the patient's back if she's having back pain. So what we know about ambulation and positioning in labor is upright positions and mobility improve the intensity of contractions, yet women have less pain. So let me say that again. When patients are upright, when they're moving around, when they're mobile, any type of upright position, even if it's with an epidural, contractions are more intense, so they're stronger, yet the patients experience less pain. So any type of upright position is best. Epidurals decrease the freedom of movement. So you want to encourage ambulation in patients that don't have an epidural. If they do have an epidural, you want to, at a minimum, change their position every 30 to 60 minutes. A lateral position or left tilt in bed is appropriate. And we talked about how you can get that left tilt. You can in the OR, you put just a bag of IV fluids under their hip. You can use a pillow, a blanket. You just don't want them flat on their back. You can put a tilt. If the baby is OP or anterior and the mother has back pain, squatting increases the pelvic diameters and allows more room for the baby, or the knee chest position that we've talked about. So if mom is complaining about back labor, and you do your vaginal exam, you will palpate the suture line and the anterior fontanelle that the baby's in a posterior position. And patients may also use a birthing ball. Supportive care during labor and birth includes emotional support, physical care, and comfort measures, and advice and information. So it includes emotional support, physical care, comfort measures, and the teaching that goes with it. That includes the nurse, the father or their partner, doulas, grandparents, and siblings during labor and birth. And we're going to go through each of those and how you can support them. Women with continuous support in labor, the benefits: they have a decreased use of pain medications and epidurals, increased rate of spontaneous birth, meaning that they don't have to have vacuum or forceps assistance. And they also express an increased satisfaction with their birth experience overall. For those that provide labor support, the nurse should be non-judgmental in her care and listen to the patient and the significant others, any kind of concerns they have. You also act as their advocate, help control their discomfort, and always protect their privacy. So as an advocate, as a patient advocate, we hear about that a lot, but if you have a patient who is, very strong that they do say they don't want a C-section or they don't want an epidural, as the advocate, it's your job to provide them with the care that can end in a very satisfied delivery for them. So supporting them with frequent position changes and other non-pharmacological pain management will help them get that delivery that they need. On page 453 in your book, there's box 19.9 that provides some guidelines for supporting the father or the partner, significant other. Doulas are specially trained, experienced labor attendants. Their role is to provide emotional and physical support. Their role is not to provide any kind of medical care. So they're not adjusting monitors, IV fluids, doing vaginal exams, taking vital signs. They're not doing anything like that. Their entire role is emotional and physical support. With grandparents, if you have a grandparent that's supporting a grandmother, a great-grandmother that's supporting a patient in labor, you want to be sure and treat them with respect. They have obviously been there and done that. And although times have changed and we know things different than we did then, you still want to, incorporate your teaching in a way that is positive for them and makes them feel involved and respected. As far as having siblings at birth, the number one factor that's most important is to make sure they are prepared with some type of class, and that can decrease their fears. And the next couple slides is a case study that I will post for class discussion for you to respond.